Welcome to our policy webinar, everyone. Today's webinar will be led by myself, Carla Lott, the Director of Congressional Relations, and Julia Dreyer, Director of Federal Relations. This is the National Council of Urban Indian Health 2020 Legislative Update. We're going to cover past accomplishments and future goals. The National Council of Urban Indian Health is, as you know, the only national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent healthcare services for American Indians and Alaska Natives living in urban areas. Created in 1998 by urban Indian leaders to advance healthcare of American Indians and Alaska Natives, we are advocates for Indian healthcare with Congress and the federal government. We provide technical support to UIOs for implementing quality, accessible healthcare services. And we provide technical assistance to support the 41 Title V urban Indian organizations across the nation. So NCUIH, as you'll see on my slide here, our work intersects from between the Technical Assistance Research Center, we lovingly call them our TARC department, to the Federal Relations, and then Congressional Relations and our programs and development. NCUIH provides UIOs with training, technical assistance, and research support to help them implement and appraise quality, accessible, and culturally competent or appropriate healthcare services for AIANs living in urban areas. NCUIH hosts the Knowledge Resource Center, a knowledge hub on AIANs living in urban areas. The KRC aims to improve the lack of health information on the conditions of urban AIAN through information dissemination. NCUIH educates Congress and federal agencies about the health and wellness issues experienced by urban AIANs and the urban Indian health programs that serve them. Our mission: NCUIH envisions a nation where comprehensive, culturally competent, personal and public health services are available and accessible to American Indians and Alaska Natives living in urban communities throughout the United States. NCUIH's members provide health care to the substantial part of that fast-growing AIAN population which lives in metropolitan urban areas and off reservations. We're also the national membership nonprofit organization devoted to the support and development of quality, accessible, and culturally competent healthcare service to American Indians and Alaska Natives living in urban areas. What is an urban Indian? An urban Indian or Alaska Native who lives in an urban or suburban area. Urban Indians may variously be permanent residents, including long-term residents, forced residents, or medium and short-term visitors, such in the case of higher education. Approximately 78% AIAN live in metropolitan urban or suburban areas. We look forward to the 2020 census because NCUIH believes that this number will actually, due to population growth, show at a higher percentage rate. Specific issues include migration, identity, intertribal, pan-Indian perspectives. Urban Indian health programs were created in 1976 after the relocation era by tribes advocating for treaty health rights off reservation. UIOs are a part of the three-pronged health system: IHS, tribal, and urban Indian organizations. We refer to this system as the ITU system. And some of the key legislation includes Indian Healthcare Improvement Act, the Affordable Care Act, Social Security Act, among others. Sorry guys, I muted myself. Now we'll talk about the different eras that we have gone through to get us to the point of why we talk about urban Indian healthcare. As you can see, we have gone through many different periods in Indian healthcare services and in Indian country, from time of first contact from the colonial period, which roughly started, we know, at 1492 and carried us on through what we start to focus in on as the termination period in 1968, and then the relocation era. As you see, we have this fantastic timeline where we go through the different eras, and now we outline the self-determination period to the nation-to-nation period to a period where we have identified as an uncertainty period, which includes the Dakota Access Pipeline, ICWA challenges, and trust land challenges. If you don't mind, actually today's webinar will have various polling questions, and I'd like to question you now. Other than healthcare, what would you say are still major issues for AIAN people related to the federal relocation policies of the United States? And I'll give you a few moments. Okay, great. Those are some very relevant answers and ones that NCUIH has identified in the past, and we do work on those issues. Thank you so much for your participation. We'll move on. All right, well, how do AIANs receive health care? Again, we talked about the ITU system, that being IHS, tribal facilities, and urban Indian organizations. The Indian Health Service is a federal agency that, of course, we know provides direct care via IHS clinics and hospitals, and provides funds for the TU, the tribal and urban, to provide direct care or compact services. Tribal, we know and respect as the sovereign nation part of the ITU system that contracts with IHS for IHS to provide some services. And then, of course, the work that we do for urbans, our nonprofit, compacts with IHS to receive IHS funds to provide direct care, and UIHPs, which are urban Indian health programs, received less than 1% of the IHS budget from the one line item, which we'll cover shortly. As we mentioned previously, UIOs offer a myriad of services. The availability of urban Indian healthcare is a necessity to AIN people who have been displaced from their ancestral lands by the federal government, maybe a life event, or by choice even, maybe searching out higher education or work opportunities, but they have the opportunity to seek out health care at urban Indian organizations. And those urban Indian organizations can provide so many different resources and healthcare opportunities, from full ambulatory, which means all weekdays access to primary care, limited ambulatory, certain days and hours access to primary care, also outreach and referral, urban Indian IHS service units, and alcohol and substance abuse services, just to name a few. Again, I'd like to poll the audience. If you could pick your level of agree or disagree. I think the provision of culturally competent services at urban Indian organizations is a strong influence on where American Indian, Alaska Native people choose to obtain their health care. As we see by the votes, it seems that culturally competent services are something that are highly important to our urban Indian communities and those individuals who use urban Indian organizations. That's why NCUIH educates Congress and our coalition of stakeholders and partners in addressing the fact that we do need to be able to provide culturally competent healthcare services and receive reimbursement rates for such services. Thank you again for participating in today's polling questions. So let's go on to the legislative priorities at the National Council for Urban Indian Health. Number one priority for us, besides funding, is to preserve the Indian Healthcare Improvement Act, otherwise known as ICIA. NCUIH continues to encourage and support efforts by lawmakers to educate their leadership and constituent base about the importance of protecting ICIA from controversy surrounding the Affordable Care Act, otherwise known as Obamacare or the ACA. It is imperative that lawmakers ensure any repeal of ACA does not also repeal ICIA. Also in jeopardy are several AIAN specific provisions in the ACA that should be retained even if it is repealed or sees major modifications. Particularly Section 2901, which ensures that IHS is the payer of last resort, and Section 2902, which authorizes IHS to collect reimbursement for all Medicare Part B services. Our recommendation is to ensure that ICIA remains permanently authorized and retain all AIAN specific provisions, notwithstanding efforts to reform or replace the ACA. We also seek to increase the urban Indian healthcare line item. Oh, excuse me, I skipped a little bit. One of our objectives or priorities for our legislative work is to fully fund IHS. And in order to increase the IHS budget, NCUIH, as part of the National Tribal Budget Formulation Work Group, has highlighted the dire need to fund IHS at appropriate levels while recognizing the threat of sequestration. IHS is considerably and historically underfunded at between 50 and 60% of need, despite more than 2/3 of American Indians and Alaska Native living off reservations. It is important to note that Medicare, Medicaid, and the Children's Health Insurance Program and the Department of Veterans Affairs are largely exempt from sequestration. IHS should be given the same favorable treatment. IHS may be funded through what are known as discretionary dollars, but the federal government's responsibility for Native American health care is mandatory, not discretionary. Our recommendation is that senior leadership in both branches must give congressional appropriators the support they need to provide more funding to IHS to better serve urban Indians. Moreover, IHS should be shielded from sequestration and freed from the constraints of the year-to-year appropriations process. Next, we talk about the increase to the urban Indian healthcare line item. UIOs only receive one line item appropriation in the IHS budget. The urban Indian health line item, UIOs, don't receive purchase or referred care dollars. They do not receive Federal Tort Claims Act coverage, nor do they receive 100% FMAP or facilities funding. In fact, a few UIOs temporarily closed during the shutdown, this past shutdown, 2018-2019, shutdown to the lack of parity within the IHS system. We recommend that there must be an increase in the urban Indian health line item to 2% from less than 1% of the IHS budget to approximately 2% of the Indian Health Service budget. We talk about preserving the Medicaid benefit for American Indians and Alaskan Natives. Under the ACA, Medicaid has been touted as the largest expansion of Indian health in a generation, having had a significant impact to both the IHS and urban health care supplementary budgets. However, some health care reform proposals have called for radical changes to Medicaid, repeal or reform of ACA, demonstration waivers, granting of expansion dollars, and work requirements. Inevitably, states would be unwilling or unable to make up ever-increasing Medicaid funding shortfalls, resulting in less coverage and reduced eligibility. We recommend if the Medicaid is to be reformed in order to limit the federal contribution and impose greater financial burdens on states, there should be a carve-out and specific exemptions in order to preserve the existing benefit for American Indian and Alaskan Natives. Next, we talk about extending the 100% federal medical assistance percentage, or otherwise known as FMAP, to urban Indian organizations. NCUIH continues to support the preservation of Medicaid and encourages the federal government to extend 100% federal medical assistance percentage to urban Indian health programs. At the time that the government authorized IHS to bill Medicaid for services, UIOs were being created by Congress. So basically, at the same time that legislation was being passed through, UIOs were being created by Congress for the need of urban Indian population. Regrettably, UIOs were left out of this legislative change that allowed tribes to bill Medicaid. NCUIH recommends and works hard to educate about the need to give or allow 100% FMAP coverage to urban Indian AIAN populations who receive healthcare services from UIOs. We talk about expand behavioral health services to urban Indian organizations. NCUIH understands the overwhelming need to improve the morbidity and mortality profiles and disproportionate rate of behavioral health issues among American Indians and Alaska Natives living in urban areas. Our recommendation is that additional grant funding is needed for UIOs to address these behavioral health issues. The definition of Indian. The ACA includes 3 different and inadequate definitions of Indian. These ACA definitions are inadequate are inadequate because they include only members of federally recognized tribes, which leaves out many American Indians who are served by IHS, including descendants, and many urban Indians and many California natives. I believe actually that I skipped over one of the talking points on my slide, so I'm going to go back to talk about the Federal Tort Claims Act, otherwise known as FTCA, coverage to urban Indian organizations. Without FTCA coverage, UIOs must buy their own malpractice insurance. Given that UIOs are provided less than 1% of the IHS budget, malpractice insurance is a huge hit on their budgets. We recommend that FTA should include UIOs and under the same standards as a participating health center or its providers, medical malpractice liability protection should be provided to UIOs at no cost. Next, we'll talk about NCUIH's legislative accomplishments in the 116th Congress. So that we talk about the first session. So one of the biggest accomplishments that we have had in the first session and within the most recent past is the urban Indian legislation that is currently moving through the halls of Congress. We'll start with the Urban Indian Parity Act of 2019. Senators Tom Udall, Vice Chairman of the Senate Committee on Indian Affairs, and Representative Ben Lujan, Assistant Speaker of the House, along with Senators Heinrich and Representatives Holland and Torres Small, introduced bicameral legislation to improve Medicaid for Native patients who receive services at urban Indian health programs. The Urban Indian Health Parity Act is also co-sponsored by 11 other senators and 16 other members of the House of Representatives. For the most part of the first session of the 116th Congress, we have worked very hard in support of this particular bill, and it has had 2 hearings in the House, both of which we have been able to provide in-person testimony for. The Healthcare Access for Urban Native Veterans Act, again, Senator Tom Udall, Vice Chairman of the Senate Committee on Indian Affairs, and Representative Khanna announced the introduction of the Healthcare Access for Urban Native Veterans Act, a bill to improve healthcare access for Native American veterans by providing the Department of Veterans Affairs coverage for care that Native American veterans receive at urban Indian health centers. This legislation is also co-sponsored by 7 other senators and 27 other members of the House of Representatives. This bill passed out of the Senate Committee on Indian Affairs and was shortly placed on a hotline, but unfortunately it did fail on the hotline for the first Congress. Oh, sorry guys, you know what, when you're talking so much and reading all this important information, sometimes you get a little discombobulated. I'm sorry. We'll talk about the Urban Indian Health Line item increase. In early 2019, NCUIH testified before the Interior Environment Appropriations Subcommittee for an increase of the Urban Indian line item. $81 million for the Urban Indian Health line item was included in a draft fiscal year 2020 interior funding bill released by the House Appropriations Committee soon after. NCUIH supported this action by Congress. As we all know, Congress did not complete action on appropriations before the end of the fiscal year on September 30th, 2019, and Congress was forced to enact a continuing resolution, or a CR, in September 2019 that funded the government through 21 November, and a second CR through December 20th was needed to allow the House and Senate to complete work on full appropriations for the rest of FY 2020. On December 16th, lawmakers released details on a deal to complete appropriations for the fiscal year through two spending packages, or otherwise known as mini-bus measures, at an estimated cost of $500 billion. And President Trump signed both those measures on December 20th. Although we did not receive the original $81 million that came out in the draft appropriations bill from the House, we were able to secure a $6 million increase for the Urban Indian Health line item. Going back to the spending packages, these provided over $6 billion for the Indian Health Service, $243 million more than fiscal year 2019, and $138 million more than the President's budget request. Indian Health Service seen a 4% increase over FY19, and again, the agreement included a $6 million in additional funds for the urban Indian health programs. This, we believe, is a long overdue increase, and although it is an increase, and we do appreciate all the legislators and stakeholders work on this increase for our Urban Indian Health line item, we believe that this increase is not the increase that NCUIH has supported in the past, and we will continue to work hard to see future increases to our line item. The health extenders, including SDPI and CHD, have been extended until May 22nd of this year. This date provides additional time for negotiations on the longer-term reauthorization, and NCUIH will continue to support the programs so that they are extended for a longer term, likely 5 years, and to fight for any increases we can for the programs that still have not seen any, but rightfully so deserve the work of all of the partners and all of the coalitions that work in tune for Indian country and healthcare measures. NCUIH provided testimony on the House and in the Senate, both in person and for the record. NCUIH has provided more testimony this Congress than in recent previous congressional sessions. NCUIH leadership has spent countless hours in educating and supporting stakeholders to the needs of urban Indian organizations. We have presented, I'm glad to say, in person twice in the House on current urban Indian legislation that is in both the House and the Senate. We were able to present before the House Indigenous Peoples Subcommittee legislative hearing on HR 4153, and we were also able to present before the House Committee on Veterans Affairs Subcommittee on Health oversight hearing entitled Native Veterans Access to Healthcare, the Healthcare Access for Urban Native Veterans Act. Also, we're pleased to announce that NCUI's Executive Director presented in person before the House Indigenous Peoples Subcommittee at an oversight hearing entitled Reviewing the Broken Promises Report, examining the chronic federal funding shortfalls in Indian country. Some of the important legislation that happened in the 116th Congress in the first session. Well, of course, we would say that the legislation that covers urban Indian issues, such as Urban Indian Health Parity Act, that's the Senate Bill 1180, and on the House is HR 2316, provides 100% FMAP. Healthcare access for urban Native veterans, of course, is the IHSVA reimbursement agreement, the Indian Programs Advancement Appropriations, and the IHS Advanced Appropriations Act, the Community Health Investment Modernization and Excellence Act, that was to reauthorize SDPI, CHC, and the National Service Corps, the Native American Service Suicide Prevention Act, and the Department of Veterans Tribal Advisory Committee Act, and that was to establish the Department of Veterans Affairs Advisory Committee on Tribal and Indian Affairs, and of course the Medicare for All, which was to establish a Medicare for All national health insurance program. So those all were happening in the first session of the 116th Congress. Some things that will continue in the 116th Congress for NCUIH. We will continue to work on appropriations. We will continue to educate stakeholders in the importance of increased funding for the Indian Health Service and at other agencies affecting healthcare in Indian country. IHS must be funded at an appropriate level to ensure quality, culturally competent healthcare to Indian country. This includes advanced appropriations and protection from sequestration. As we all know, we can recall, the 2018-2019 shutdown, the 35-day shutdown, had dire effects on UIHPs. As you are all keenly aware, this shutdown impacted IHS as the Interior Environment Appropriations Package had not yet been passed. NCUIH circulated a survey to UIHPs in the beginning of the shutdown, outlining the impacts the shutdown have on urban Indian healthcare, and thanks to the great information that was provided by the UIHPs, NCUIH created detailed informational resource material about these impacts and circulated that resource to members of Congress. These efforts led to a hearing on the shutdown impacts on Indian country before the House Committee on Natural Resources, where a NCUIH board member testified on behalf of Indian Health. Key findings include that UIHPs operate on a very low margin and that all aspects of the urban Indian healthcare delivery system were impacted. NCUIH works tirelessly to ensure that the special program for diabetes program for Indians is permanently funded. When the President signed the budget measure in December 2019, the agreement included a 5-month extension for SDPI and CHC until May 22nd, 2020. This date provides additional time for the negotiations on a longer-term reauthorization. NCUIH continues to work closely with our partners like the American Diabetes Association, Juvenile Diabetes Research Foundation, and the Endocrine Society, and of course the National Indian Health Board. NCUIH has held several Hill Day activities along with training on how to meet with stakeholders, and NCUIH has supported our UIHP membership and board directors in their relationship building with Congress. NCUIH has worked to strengthen and support existing professional relationships between the other national organizations to create a unified effort on behalf of Indian healthcare when that work is within the mission of our organization. Some of the presentations that we have done over the last few months and throughout 2019, we were able to present at the National Congress of American Indians Mid-Year Conference, the National Tribal Budget Formulation Work Group, the National Indian Health Board's 2019 Tribal Public Health Summit, the National Indian Health Board's 2019 Behavioral Health Conference, the Native American Journalists Association, the National Caucus of Native American State Legislators. We've provided presentations at the California Consortium for Urban Indian Health Conference and Policy Panel, and the Office of Urban Indian Health Programs meeting and board training in Billings, Montana. Some of our continuing legislative priorities in the 116th second session. We hope to see Congress continue to create additional good works on the foundation and the basis that we provided with our expert guidance and resources throughout the 116th first session. And of course, we'll continue to work on FTCA, FMAP, IHS DA MOU, the Urban Indian Health line item increase, appropriations, and SBDPI. Now I'd like to actually put up another polling question if I could. As we continue to go through into the 116th Congress, we'd like to know what other healthcare issues do you believe NCUIH should focus on in their future work that we haven't already spoke of today? Thank you for your answers to the polling question. There have been some past activities that NCUIH has been involved in some of the areas that you have identified. And as we go forward with our partners and our national coalition of related healthcare partners and stakeholders, of course, we're always looking for additional ways to fund work that would allow us to dive deeper into those areas. And we're always looking for initiatives that we can support. And we're always willing to assist our partners with their work also. So we have at times been able to put together partnerships that have allowed us to work on some of those issues, and we really appreciate your answers. Thank you so much. As we go forward and we look about what is to come for the future of these issues that concern urban Indian healthcare and Indian country as a whole, we must also look to who is serving us in the halls of Congress and who may or may not be in the next Congress. So we put up a slide here that will show you quickly the members that are not seeking re-election, and you'll see by our key that the white outlined have signed onto one or more NCUIH bills. So this is going to actually make an impact on the work that we've done. These members either retiring or not seeking re-election for next year's Congress. The green is from a state with an urban Indian health program, and yellow is a senator or representative from a NCUIH urban Indian health program, or represents for a NCUIH urban Indian health program. So you'll see that we're always constantly looking at who our friends are and who we should be making friends with and who is paying attention to the work that you all are doing out in the field and how we can best support that. I do have one last polling question before I turn it over to the Director of Federal Relations. I kind of got out of sync with when I was supposed to bring up the polling questions, so I appreciate your flexibility. My last polling question here today is, how comfortable are you in speaking to stakeholders about the importance of urban Indian health? Great, thank you for your answers. One of the things that I have been concentrating on since I came to NCUIH last March is to assist our stakeholders, our partners, and our membership base in their ability to advocate to not only their personal representatives, but as a whole to all of nationally, at a national level, to be able to speak about urban Indian healthcare issues and the needs of urban Indian healthcare across the nation. And so I will, in my role, continue to support those efforts and hold additional trainings and support those who request that sort of activities from us. So I appreciate your answers. They help tremendously. Next, I'd like to turn it over to Ms. Julia Dreyer. She is the Director of Federal Relations for the National Council of Urban Indian Health, and she will give us a little bit about what to watch in 2020 on the federal relations.
Thank you so much, Carla. First, I want to go over a few things to watch for with respect to Medicaid. Recently, Kansas announced that they have reached a deal to expand its Medicaid program, which would make Kansas the 37th state to expand Medicaid. Of the 13 states other than Kansas that have not expanded, 11 are led by Republicans, which may impact whether they expand. Mississippi has been reported to be exploring expansion, and Oklahoma voters may get expansion on this year's ballot. Block grants under Medicaid also seem poised to become a trend in the coming year. The Trump administration has repeatedly indicated a desire to allow states to include block grants in their Medicaid programs. Block grants would impose a cap on Medicaid spending, as opposed to the current open-ended financing system that provides for unlimited federal matching for all state spending under Medicaid's federal rules. Although the future of block granting had seemed uncertain, in November, the Office of Management and Budget Regulatory Review was abruptly withdrawn. On January 19th, the Wall Street Journal reported that the administration plans to release block granting guidance for states as soon as this month. Block granting has the potential to limit Medicaid expenditures, so we will certainly continue to track this issue and provide updates. Despite pending litigation, including a few judgments that blocked Medicaid work requirements in Kentucky, Arkansas, and New Hampshire, some states are still seeking to implement work requirements through Medicaid waivers. In Michigan, where work requirements took effect this year, a lawsuit is pending, and in Oklahoma, the waiver with work requirements is still pending before CMS. Most recently, Nebraska proposed work requirements in a two-tiered system, perhaps to avoid judicial scrutiny. In Nebraska's proposal, work requirements would apply to the expansion population for a prime package of benefits, which would include vision, dental, and over-the-counter drugs. But the work requirements would not apply to the basic Medicaid benefits package. Arizona, Utah, and Wisconsin have work requirements that have been approved but not implemented, while Montana, Nebraska, Oklahoma, and South Dakota still have waivers pending before CMS. In addition, in October, the administration issued an executive order on protecting and improving Medicare for our nation's seniors. The executive order calls for several changes to the Medicare program, including proposed regulations, and seeks to protect and improve Medicare by building on all aspects of the program that work well. Analysts explain that it is unclear exactly what will result from actions undertaken pursuant to this executive order, as much will depend on the mechanics of the rules. But that said, some of these proposed regulations are likely to come out in the next year. Future actions could exacerbate the imbalance between traditional Medicare and Medicare Advantage, allow seniors to opt out of Medicare while still receiving Social Security retirement payments, expand Medicare medical savings accounts, and identify and remove barriers to private contracting between providers and their patients, rather than requiring the providers to bill under Medicare. In terms of the Indian Health Service, the agency will be releasing its determination on behavioral health funding related to the NTAC recommendations, and will also be releasing its decision regarding the Special Behavioral Health Program opioids funding. It also will disseminate increases to UIOs based on the increase included in the most recent appropriations package and the IHS formula. The fiscal year 2022 National Tribal Budget Work Session will take place February 13th and 14th at a location to be announced in Crystal City, Virginia. In addition, with respect to budget formulation, on January 29th and 30th, IHS will hold webinars where area representatives will give 15-minute presentations of their priorities. NCUIH will also present on January 29th. After the sessions, the Tribal Budget Formulation Work Group will prepare a fiscal year 2022 recommendation, which will inform IHS's budget recommendations. The work group will also start to prepare for the HHS Tribal Budget Consultation session. With respect to the HHS Tribal Budget Consultation, regional HHS consultations have been scheduled. They will take place in Region 1, May 19th in Boston, Region 2, May 21st in Syracuse, New York, Region 3, July 28th through the 29th in Virginia, Region 4, June 16th through 17th in Miami, Region 5 is to be determined. Regions 6, 7, and 8 will take place between July 14th and 16th in Denver, Colorado. Region 9 will take place July 9th and 10th in Arizona, and Region 10, April 22nd through 24th in Anchorage. Several additional items to keep an eye out for are on this slide that we expect to happen in 2020. First is the President's budget, which is slated to be released on February 10th, providing recommendations to Congress for appropriations. Congress will consider the proposal and begin its appropriation process. Some recent updates for appointments. Rear Admiral Michael Dubiaki was nominated in the fall for the Director of IHS, which is still pending. A hearing was held in December to consider his nomination. On January 9th, the Senate confirmed Paul Ray to serve as the administration's regulatory chief as the administrator of the Office of Information and Regulatory Affairs, or OIRA, which is an agency within OMB that reviews federal regulations. Ray was confirmed at the 50-44 party line vote. Stephen Hahn was confirmed as the FDA commissioner after the resignation of the prior commissioner. There continues to be no nominee for the HHS Inspector General, with the former Inspector General having resigned in April. The acting Inspector General also retired on December 31st. The administration also seeks to continue to make prescription drug pricing a priority. For instance, a proposal is forthcoming to tie Medicare reimbursements to foreign countries' drug prices. The administration also recently released a proposal to bring in cheaper prescription drugs from Canada. However, it appears unclear whether it would actually lower costs given the regulations that would be needed related to things like safety testing and managing product recalls. I will continue to track the updates regarding prescription drug pricing and new regulations that come out and provide updates as we receive them. It is also likely that the administration will continue to look at efforts to scale back the 340B prescription drug pricing discount program, due in part to the expansion the program has seen in recent years. Thank you so much for joining us today. Those are the updates that we have for what to watch for from federal agencies in 2020. And as a reminder, please make sure to take the evaluation survey, which is in the notes on the right of the screen.